All right. So I don't want to be the downer after that's such a nice video, but I think our goal here is to observe some of the ethical issues. I'll try to keep it as short as possible. If you can scan the QR code, this is not for your attendance. This is just to help us identify maybe the issues that are important for you, and I think it will help the very young society understand what the issues confronting them are. And I'll be trying to discuss them in a bit, right? So I've been asked to talk about the ethical issues. So my first question that I ask here is, what are your concerns regarding ECMO? Obviously, with availability, these are mostly found in the urban areas, and the other areas of the Philippines may not have it. You talked about team skill and know-how. Apparently, we have a lot of the physicians, but as you know, in terms of the nurses' brain drain, it's one of the bigger issues that we have too. Is it initiation and discontinuation decisions, especially for conscious patients who are not meant for any other options but to be maintained on ECMO? Is it the financial burden, or is it management conflicts? So far, based on the answers here, I cannot project it there. The first one is really team so far. Team skill initiation, followed by availability, and then the financial. Now availability is number one. All right, I'm sure this is going to change as time goes by, and I'll mention it in a bit. Now, the next question is, what are your ethical concerns with ECMO? I'll try to observe some of this, and maybe we can discuss this partly in the open forum. So for the next few minutes, I just want to start off by saying that in terms of contemporary goals of medicine, these are the four basic goals, but our challenge will be to care for those and cure those with a malady, especially for caring for those who cannot be cured. And last is, of course, avoiding a premature death and pursuing a peaceful death. Now, as you've seen with what they've done with ECMO, we've already avoided premature death in a quite significant amount of patients. So that will be the focus for this afternoon's talk. I'd like to focus first on two parts, which are important. We'll talk about health equity and health inequity. It says that our goal is really the attainment of the highest level of health care for all people, and that it's, as much as possible, we allow patients to attain their full potential. As you saw with the success stories that they've had, the survival of the patient was made possible through ECMO itself. However, there are certain problems that can arise, and this will be health inequity. For health inequity means there are preventable differences in the burden of disease, and they're experienced by socially disadvantaged populations. And we'll show you that sometimes the decision as to whether patients can undergo ECMO or not is affected by implicit bias of the physician. Now, these are closely linked with a lot of disadvantages. Now, just to point out that in the Philippines, 60% of the income will be spent on food, and the monthly income of the Filipino is how much? It's 19,000 pesos. So in terms of 60%, how much does it leave behind for healthcare? That's 40%. That's for a single individual. And those will be the challenges. That's why around 10 million Filipinos above 30 will probably die before their 70th birthday. As someone turning 56, that worries me now. Right? So let's talk about the natural history of disease. Normally, our patients probably would fall under this one. When our patients have critical illness, our goal, of course, will be to attend to these patients, whether they proceed to recovery or end of life. The challenge will be informed decision-making, whether they will undergo ECMO or not. Of course, the goal is to treat or to palliate, or of course, this will be part of the healthcare team's recommendation. And then what is important is to continue or to withhold. And I think this will be one of the greatest challenges for patients who do survive, but you cannot take them off ECMO, especially when they are awake and able to make decisions. And those will be some of the challenges. So the goal is to talk to the patients and the surrogates, and this will be part, of course, of your shared decision-making, which has been recommended. So most of the patients, obviously, that will be included here will be critically ill patients, and it is a challenging time to make decisions when you are critically ill. So our goal here is how to initiate and then go to termination. We talk about effectiveness. Availability was the issue that was asked. Now, affordability and sustainability are the major issues too, as was mentioned, in terms of the cost for continuing treatment. So effectiveness, we'll have to talk about informed consent, as well as, is it a bridge or is it a destination? The problem is if it becomes the destination. Maybe in the future, it may be something you can bring home and serves as the destination for the patient, but currently it is not. So for affordability and sustainability, what will be our issues here? Of course, prolonged ECMO, euthanasia or dystonia. Dystonia means prolonging death unnecessarily for patients who are ultimately going to reach that end. And lastly, standoffs. when we have disagreements with family members or other members of the healthcare team. So we have to understand duties of care and what we call goals of care. The goals of care are determined by the patient. Why do I want to be placed on ECMO? And the duties of care are what we as physicians deem important, so we have to place this patient on ECMO to achieve what we want medically. Of course, the challenges here will be the patients, followed, of course, by family decisions, and of course, it will be the ECMO team. The ECMO team also has to be desensitized in cases wherein there may be problems, especially in terms of removal them from ECMO when there are disagreements. And lastly, healthcare institutions. Right, so the important thing really is the ECMO program. And they said these are important considerations, and I highlighted the ones that may have ethical issues. It's really consent process, which also involves patient selection. The protocols, I think, are not so much of an ethical issue, but the family engagement, duration of ECMO therapy, managing impasse when you cannot have an agreement as to what to do, and then futility. So they say there are three basic questions that may need to be answered, and these are, do we have enough trials and evidence accompanying this form of management? And as you've seen, the Philippines has already produced quite a significant amount of data, and I think the leptospirosis data is quite interesting. Now you talk about allocation, decision-making, and limiting care, and lastly, of course, death and organ donation. I would like to focus a bit on organ donation, but due to time constraints, I do think that's one topic you may want to talk about in the future. So I'll ask a few questions. Should discussions, maybe just a show of hands to maintain the energy that our first two speakers had, should discussions on ECMO be conducted early on and included in advanced care planning? How many of you think that should be? Okay. Or should these discussions be initiated at the clinical illness when it ensues? Any? It's sometimes difficult, right, to bring ECMO up with a patient who's not necessarily that ill, but maybe to give them an idea. And just looking at the COPD course here, I just want you to show you that despite the fact that it is one disease in name, the outcomes will be they're very different, as well as trajectories. So it may be important to tell your patients at the onset, if you expect them to progress, that they may need some interventions in the future to bring it up. So that once you bring up ECMO, it will not be a major issue. Next question, should ECMO discussions be limited to patients who will be able to withstand the financial rigors? Well, let's say it's a vagrant in the street. Should you offer it? Oops, I answered it already. All right, but anyway, we talk about implicit bias. What do I mean by implicit bias? There's stereotypes and they're unconsciously endorsed. So what does this mean? If it looks like the patient is poor, we probably will not offer it. But how do we know that the patient cannot have access or cannot find means and ways? You will be surprised at the efforts of the Filipino who will want to search for a cure. So it's influenced usually about how information is processed and perceptions of reality. So we have to be careful about implicit bias when that we do not refer a patient who will benefit from ECMO because we believe this patient will not be able to afford it. Right? So we have to understand that the limitation should be based basically on technical futility and terminal short-term prognosis as untreatable by ECMO. What will pose challenges will be the last two: a low probability of successful bridge to recovery or transplantation, and quality of life judgments. And that's one of the most difficult parts. What do we mean by quality of life judgments? That will be usually dependent on a patient. They may be bedridden, but to see their family, even if they're bedridden, might be quality life for them. So those are the things that have to be qualified. Okay, a next show of hands. Should the physician have the choice whether ECMO is offered or not? Agree? Or should patients and their families be offered the option regardless? Okay, so you see that there are differences in opinion. So one we point out here is that when we do make decisions, these are based on medical indications, patient preferences, and I want to emphasize the last two, quality of life and contextual features. It may be a bridging that this patient wants to see a loved one who is coming home after a month. And after that month, the patient is willing to go. Then this bridging procedure may have a destination, even though clinically or medically it may not have one. So just to emphasize, the communication with patients and families have to be a closed circuit or a closed loop. That means it has to have opening as well as a closing. And we have to elicit understanding, communication, educating, and negotiation in the process. Now, I do want to point out that we have to avoid this because normally doctors still sometimes tend to be paternalistic in that I decide for you, which should never be the case. It may be also I give you the facts, but it doesn't help patients when you just give them facts. So it may be a combination of both deliberative and interpretative. It means you will tell your patient your preference, that you think they will benefit from it, but at the same time, you will help the patient find for himself that this is useful for you. And that is what we call interpretative, where you give the facts and help the patient find this. So it's not a matter of just having the patient say yes or no, because they may say no the first time around or a second time around. But we do have to understand when talking about informed consent, it really needs time and repetition, which needs to be processed every time. Okay, let me now go to the last part. What do we do now for patients with bridge to nowhere conditions? That means we do ECMO, we can't take the patient out of ECMO, and there's really no specific destination like a transplant, or the patient's not waiting for anything else. Should the patient have the final say to continue ECMO? How many say yes? If you think it's futile, but the patient says, I still want to be placed on ECMO, it's already their 200th day on ECMO, and they've consumed your hospital's resources. It's a challenge, right? And can the healthcare team unilaterally decide to withdraw? What do you think? Okay, there's a difference here between conventional and crisis situations. During COVID, as much as distressing as it may be, ethicists will say you can unilaterally withdraw if someone else will benefit from it because it's a crisis situation. But that is going to be very heavy and morally distressing for any clinician. In the conventional setting, however, we do have to consider talking to them. So the last few slides, there are certain considerations that we have to take note when we manage critically ill patients. That means the first one is the goal of withdrawing treatment to remove this when they are no longer desired or do not provide comfort. Anything can be withdrawn. The withholding is morally equivalent to withdrawal. So not starting and withdrawing are morally equivalent. Although for most people, it may be more difficult to withdraw emotionally. But ethically, there is no difference. Then the action should be not hastening the death of the patient, but allowing the natural process to take its place. As we said, any treatment can be withheld or withdrawn, and it is still a medical procedure. So if you are going to withdraw your ECMO, you have to be sure that your patient is ready for palliation and to address any issues that may come about. All right? So these are some recommendations for withdrawal of life-sustaining treatment. So as we said, when you discontinue it, it allows a patient to die from urginal disorder, and it is not different from withdrawal. And one way to limit the challenges is, of course, identify which patients will truly benefit from ECMO. That means avoid them in the first place in patients who will not most likely benefit, and if it's not concordant with their values. So it really starts off at the onset in identifying the patients. Now, for the shared decision-making, remove barriers to understanding, make sure that you understand why patients are holding on to unrealistic hopes, and evaluate the risks and benefits and have frank discussions. I got this from a journal. Okay, I'm sorry, my being old prevents me from seeing it clearly, but this is supposed to be whether family meetings are held on ECMO. This now gives time durations, as you will see, that gives you as to when ECMO should be sustained, and it gives you specific things for initiation, continuation, continued, and end-of-life discussions. So it tells you whether meetings were done, what were the purposes for the family meetings. This would be followed now if a meeting did not occur, why? So you want to identify also why meetings did not take place. And lastly, you want to see the outcomes of a meeting. This might be an idea for a good paper in terms of our ECMO to identify in our setting how we do our family meetings for this, all right? So how do we resolve dilemmas when we're at an impasse? Identify clinical issues, legal issues. We have system issues. I want to point out a bit about cultural issues in the Philippines as well as ethical issues. Review what principles are at stake, what are the options to continue after withdrawal, if there's still any other option. Pros and cons, act, and then follow up and evaluate. Just understand that the Philippines has over 170 ethnic groups, and understanding may be different for each individual. That economic disparity is a problem, as well as the perspectives of healing may be different as well. So to understand that Western medicine may be combined sometimes with other forms of therapy. So Just make sure that when you discuss, make sure they're patient-centered and prepare the patient for continued decline if they're not improving. And try to obtain the surrogate decision maker if they are not able to make decisions for themselves. I just want to point this out. In the Philippines, especially if you're from Quezon City, surrogate decision makers are not automatic that if you're married, it's your spouse, or if you're single, it's your parents. So there's a right to care card that is carried in Quezon City where it actually announces who the surrogate decision maker is. There's a QR code that tells you who will make the decisions. So I don't want to focus on this, but there should be also a determination of death protocol if we plan to discontinue ECMO for our patients, which I think should be at the topic of another complete lecture all in all. So I promise to stick to time and keep it short to have an open forum. We have to understand that there will be patients who will survive and there will be patients who will go the opposite direction. The goal of ethics really is just knowing the difference between when you have a right to do and what is right to do. So with that, thank you very much all for your attention.
Thank you to our distinguished speakers. Now I invite them to come up the stage for a short Q&A. The floor is now open for any questions that you might have to our three distinguished speakers, to Dr. Barrett, who introduced the concept of ultra-protective ventilation, to Dr. Garcia, who enumerated the significant strides our Philippine team is making with regards to ECMO, and to Dr. Patrick Gerard Moral for the different ethical issues on ECMO. Maybe I should start I should throw the first question. To Dr. Barrett, we know that for patients, specifically patients with ARDS, the typical recommendation based on ARDS network, our tidal volume should be between 4 to 6, although Dr. Garcia mentioned that locally they typically set their tidal volume to 4 mils per kilogram. For the ultra-protective ventilation, how low can we go with regards to the tidal volume?
Yeah, so for many of our patients, particularly when they're very early on, at the most severe part of their illness, when their compliance is very, very poor, we're often at less than 1 mil per kilo. So for some of those patients, and it's not that we want them necessarily at 1 mil per kilo, because they get a lot of atelecta trauma, they've got complete lung collapse, and that may not be great for the lungs, but the alternative is giving them very high pressures. So for some of them, and thinking particularly some of our patients with very severe pneumococcal pneumonia and staphylococcal pneumonia in combination with, say, influenza, they're down at 20, 30 mil tidal volumes, so a quarter of a mil per kilo. It's tiny, tiny.
Quite low, Doctor.
Yes, quite low.
To Dr. Garcia, she mentioned that based on the experience of National Kidney and Transplant Institute, that the survival rate is around 75%. Do you have at least, Doctor, the factors that affects the survival of these patients? I mean, does the survival is dictated by, for example, proper patient selection, the early initiation of ECMO, or other factors?
Yes, Doc. Actually, patient selection is key. We have an ongoing study on these patients. Actually, majority of our patients are young patients without comorbidities, because we know that leptospirosis is an occupational disease. So these are really healthy individuals who just develop an acute illness. So I think we also do early ECMO. We don't wait for 5-7 days to do ECMO. So patient selection, these are young patients, early ECMO, and that's it, sir.
Thank you, Doc. Maybe for Dr. Barrett and probably to Dr. Garcia as well. Locally, I've seen that we've used ECMO mostly for patients with leptospirosis and even COVID, right? So what other disease entities that we typically use ECMO, number one? And number two, is there any difference with regards to the outcome as to the disease the primary disease that dictates this patient's outcome on ECMO?
So there's definitely a difference in outcomes. So in our practice, if we have a patient, say, for example, with severe asthma, who has a viral trigger, provided that patient has not arrested prior to the commencement of ECMO, their outcome is nearly 100% survival. Patients with severe pneumococcal or staphylococcal pneumonia, if they have essentially lung failure with a little bit of noradrenaline, their survival is 80-ish%. If they've got multiple organ failure with liver, kidney, gut, etc., their survival is 50 to 60%. So not only is it the underlying diagnosis that's important, but also the severity of illness and any comorbidities. And the more multiply comorbid the patient is, the less likely they are to survive. We also think that frailty is really important. So if you have a patient who on a normal basis can't get out of bed or can't do their normal activities of daily life, they're really very unlikely to survive. And I think that all speaks to the ethical application of advanced life supportive therapies.
Thank you, Doctor. To Dr. Moral, since you've mentioned that there are several ethical issues that might be connected with the use of ECMO, do you have an idea, Doc, how involved, for example, the ethics committee of each institution has with ECMO, and what do you think, how early should be the ethics committee be involved, just in case?
All right, I think basic ethics should be the part of the armamentarium of any physician. If you correlate this can be applicable to any intervention, whether it's your LVAD, your mechanical ventilator, for a patient. Now, I think the involvement of the ethics committee primarily will be usually to resolve an impasse, whether it's in terms of offering this to the patient. There's a discrepancy between one physician's decision over another that cannot seem to be resolved, or between the family and that of the healthcare team as well. I don't think you necessarily have to involve the ethics committee, one, due to a scarcity of ethics practitioners in the country, and second is that I do think this can be resolved usually with just communication in terms of how, whether this is important for the patient. As mentioned, selection is important. If you believe a patient will probably be maintained on this forever, and now you take the contextual features, says family will not have the money to sustain it beyond what is normally recommended, then you do have to take serious consideration. And if you need the help, then that's fine. You'd call the ethics committee. Usually they say within 3 days, if not resolved an issue within your brain, probably call the help of an ethics consultant or an ethics committee.
Thank you, Doctor. Due to the interest of time, we'll probably forward other questions to our distinguished speakers. At this point, on behalf of the Philippine College of Chest Physicians, it is my privilege to present the Certificate of Appreciation to Dr. Nicholas Barrett for being our speaker on the pulmonary patient on ECMO during the 43rd Annual Chest Convention given this 7th day of March 2024 at EDSA Shangri-La, Manila, signed by Dr. Eileen Aniceto, PCCP President, Dr. Virginia de los Reyes, PCCP 43rd Annual Chest Convention Overall Chair, and Dr. Albert Albay, Scientific Chair. I also present the same certificate to Dr. Joanne Kathleen Hineta Garcia and Dr. Gerard Patrick Moral. Once again, thank you to our panel of speakers. Ladies and gentlemen, please be reminded to scan the QR code that is flashed on the screen. You will also see the schedule for the rest of the day. Just a reminder for everyone to please be back here at 3:15 in the afternoon for the continuation of the plenary session. Thank you.
I'm Dr. Anthony Perez. I'm the current medical director of St. Luke's Medical Center Global City. This is actually the first training course in extracorporeal membrane oxygenation being held here in the Philippines. So we're very glad to be hosting this first ECMO course, and we believe that this is very vital in advancing the critical care medicine in the Philippines.
The purpose of this course is really to find a core group of physicians or ECMO specialists to help them teach the future physician leaders of ECMO in the Philippines.
So this whole thing is basically we want to simulate the environment of the intensive care unit with ECMO patients. This is the first course in Philippines, and then I've enjoyed very much.
We conquer the world, just you and I. No holding us back.
It will demonstrate a lot of interesting technique that is for the safety of cannulations. Hopefully it will translate into a better patient care.
It's a pleasure to meet the team from Hong Kong and the Asia Pacific also team, learning from their group and to be able to get their strategy on how to become better teachers and trainers for ECMO.
This is our moment. We gotta take the chance to shine. The right time to own it.
I'm not sure if you guys realize this, but when you woke up this morning and you walked through those doors, you are making history. Because today is the first ever adult ECMO training course in the Philippines.
Really appreciate how you are willing to put yourself out of your comfort zone to help us teach. It's been really great. The first session really went well, and for us as instructors, it makes our experience so much better when we see you smile and say that you've learned something. So
actually, ECMO is going to support the patient heart when patient got a cardiac arrest or some cardiac problem. We can provide more treatment or more modality to help the patient to recover.
The way we like to teach ECMO is very different from the traditional way of teaching. Instead of lecturing for many hours, we like to teach them with hands-on education, and that's through the simulation that you're seeing around us. So the students actually participate and learn how to use their minds and their hands and how to work together.